Gloria, thank you so much for your talk. That was really moving. Your experience is unparalleled. So thank you very much for that. So as has been said before, the presentations are about to begin. Please, within and in between talks, when we have a chance, please talk to different people, network, mingle, ask questions as much as you can. The general format for the presentations is going to be 15-minute talks consecutively, and then we keep the questions to the end. And I think that way we can then sort of pile them and give the presenters as hard time as you wish. So with that in mind, I'm going to welcome the first speaker, Honorine Ward, who's talking about low birth weight, stunting, and intestinal microbiota in children in an urban slum in South India. Thank you.
Thank you, Dr. White-Hammond, for that wonderful story of the little child with diarrhea who got better. And that's a little bit about what I'm going to talk today. First of all, I want to thank Makaya for giving me this opportunity to talk about our work in India. And thank you all for coming. I realize that this is a very diverse audience, so I'm going to try to focus more on the global impact of the problem and not talk too much about the actual technical data. So at the outset, I want to say that this is really a multidisciplinary, multi-school, multi-country effort. And I want to acknowledge all my collaborators right up front. So we have investigators from the Tufts Medical Center, the Tufts School of Medicine, the Tufts School of Engineering, and our colleagues in India from the Christian Medical College in Vellore. So when I say we, I mean all these people. So why are we so interested in malnutrition and the microbiome? What is the microbiome? I'm sure you've heard a lot about the microbiome in the news and in the media. So just to give you a little bit of background. So the microbiome is at the center of a vicious cycle of malnutrition and infection. When we say microbiota, we are talking about the microbes that live in and on us. And when we say intestinal microbiota, we are talking about the microbes in our gut. The microbiome is the collective genes of all these microbes. And as I said, we feel that the microbiome is at the center of this vicious cycle of malnutrition and infection. So starting with infection, enteric infection, which leads to diarrhea, which we heard about, this can lead to damage to the intestinal mucosa, resulting in impaired absorption of food and nutrients, impaired barrier function, which allows microbes to cross the gut and to cause inflammation. This in turn leads to malnutrition. Malnutrition leads to decreased immune function. Decreased immune function predisposes to infection, and the cycle continues. And all of these factors can impact and be impacted by the microbiome. And added to this, there is host genetics and food insecurity. So why are we interested in this? Our hope is that we can modulate the microbiome to provide interventions for malnutrition and infection. And that's the reason why we are studying this. So just to give you a little bit about the global impact of malnutrition, I'm sure you all know about this, but just to remind you, malnutrition is associated with almost half of all deaths in children under the age of 5 years. Malnutrition is a very broad category. Stunting, or low height for age, is the most common form of malnutrition and is generally associated with chronic malnutrition. And as you can see, in 2011, there were 165 million children under the age of 5 years who were stunted. It might surprise you to know that most of these children live in South Asia, and in particular in India. So the largest number of stunted children, 61 million, live in India. And this is in spite of all the economic growth and development that India is undergoing. This is a map of the global burden of stunting. The countries in red are the countries where there is over 40% of stunting. And you can see that India is, and the surrounding countries in South Asia are among those that have the highest rates of stunting in the world. Diarrheal disease, I don't need to tell you again that this has a huge impact globally on child health. We heard the story of the baby with diarrhea. Globally, 1.3 billion cases per year, and diarrhea is the second leading cause of death in children under the age of 5, second only to pneumonia, and I'll show you the data for that. Diarrhea causes 11% of about 8 million childhood deaths per year. And again, contrary to what you might expect, the proportion of deaths that are attributable to diarrhea in children under the age of 5 is highest in South Asia. And 31% of deaths due to diarrhea in these children occur in South Asia. So here are the global causes of death in children under the age of 5. And you can see, I don't have a pointer, but that when you look at deaths overall and deaths in the neonatal period, that diarrhea is second only to pneumonia as a cause of death in these children, and is greater than both AIDS and malaria combined. So diarrhea is a huge problem. The numbers have come down recently, but the numbers are still very high. This is older data, but as I said, the numbers have come down, but it's still very high, showing that the burden of diarrheal diseases in India is still the greatest, and more than occurs in sub-Saharan Africa. So stunting and diarrhea both are very high in India. And our work is done in Vellore, which is a small town in the south of India between Chennai and Bangalore. And the study that I'm going to tell you about is part of a much larger study funded by the NIH on immune responses to Cryptosporidium in a birth cohort of children in South India. Cryptosporidium is a parasite that is a major cause of diarrhea in India, and it's also associated with stunting. The study was done in collaboration with our colleagues at the Christian Medical College and Hospital in this small town of Vellore. My main collaborator is Gagandeep or Cherry Kang. This is a huge hospital with over 2,500 beds, and it also has a very large community outreach program. It's dear to my heart because this is where I went to medical school and where I continue to work. So just to describe the study site to you, this is in a semi-urban slum area in Vellore. The map is, this is a GIS map of the study area. It's 3 contiguous slum areas. Each dot represents a house, and you can see how close the houses are together. So extremely crowded conditions and a very high population living in a very small area. The birth rate is very high, as is the infant mortality rate. And in this area, diarrhea causes about a quarter of the deaths and 43% of the deaths in the first month of life. Here are some pictures of this slum. Most of the houses have these thatched roofs and walls. Most of the houses do not have toilets. Most of the people practice open defecation. The few houses that, like this one, which is belongs to a relatively wealthy person and has brick walls, does have a toilet in the house, but the sewage is discharged into this open cesspool that is in close proximity to other areas in this area. Water is supplied by the government municipality, ranging from once in 2 days to once in 2 weeks in the summer months. It's a communal tap, and people collect water in these plastic vessels and carry them to their homes, often walking for long distances. But what I want you to notice is this open sewage drain that's running very close to the communal tap. This is the garbage dump in the area. You can see a lot of animals. Animals live in close proximity to humans in this area, so the potential for zoonotically transmitted diseases is high, and there's also, we believe, there may be a connection between animals in the house and stunting in children. This is our multidisciplinary team of physicians and epidemiologists and field workers and database managers and lab workers at Christian Medical College in Vellore. This is Gagandeep Cherikang, my collaborator. So this the little study I'm going to talk to you about today is part of a much larger study on immune responses to cryptosporidiosis. This was a birth cohort study, and we followed intensively 400 children from birth to 3 years of age. We studied their clinical problems twice a week, whether they had diarrhea or not, other things like that. We measured their height and weight once a month, and stool samples were collected once in 2 weeks, regardless of whether the child had diarrhea or not, and during an episode of diarrhea. And we also collected blood every 6 months to look for immune responses. So then we did a pilot study from this parent study. We selected 10 children with low birth weight, that is less than 2,500 grams, and stunting on at least 5 of 8 time points. And as a control, we selected a group of 10 children with normal birth weight and no stunting at any time point during the study. We studied these children from birth to 2 years of age. We looked at their clinical data twice a week. Enteric pathogens were looked for whenever the child had diarrhea, and stool samples were collected every 3 months from 3 to 24 months of age. So we had a total of 160 samples to look at. So the objectives of this study, very simply put, were to look at the effect of increasing age on diversity and abundance of the intestinal microbiota. It is known that the microbiomes of children are very immature when they are very young, and that with increasing age, the microbiome matures. And we wanted to see if this was true in India as well. And the second thing we wanted to look at was differences in the intestinal microbiota in children with low and normal birth weight. So I'm not going to go into the methods at all, but if anyone is interested, I'm happy to talk after the sessions. Here you can see the growth trajectories of the children in this pilot study. So the green lines are children with normal birth weight, and the red lines are children with low birth weight. And you can see the big difference between the two groups in the height and weight trajectories. And I should say that even though the normal birth weight groups did not have stunting and were normal birth weight, they are lower than the WHO standards, which would run above, both for height and weight. These graphs here show the stunting and underweight as measured by the height for age z-score or the weight for age z-score. And again, you can see the big difference between the children with low and normal birth weight. When we looked at the children with low birth weight, we found, as has been shown before, a very strong association with stunting. So in India, it turns out that the greatest predictor of stunting is low birth weight, implying that maternal health before and during pregnancy is also very important in the cause of stunting. These children were also underweight, as you can see, and quite a few of them were wasted. You can see that most of them, or all of them, had diarrhea. Some of them had multiple episodes at different time points from 3 to 24 months of age. The darker colors mean greater numbers of episodes. And here is another problem. So children with diarrhea are treated with antibiotics. Often the cause of the diarrhea is viral or parasitic, and the antibiotics really don't have any effect on them, but they do have an impact on the microbiome and may be responsible for some of the ill effects that happen in these children. So I'm just going to show you two pieces of data from this study. The first is on the effect of increasing age on alpha and beta diversity of the microbiome. So alpha diversity looks at diversity within groups and beta diversity between the groups. And what I want you to take away is that with increasing age, these are all different alpha diversity parameters, there is an increase in the diversity over time. Again, the red line is the low birth weight and the green line is normal birth weight children. There was no statistical difference in the rate of change between the two groups, and the same is true with beta diversity. The second is the difference in the composition of the microbiota. So this is a technique called, it's an algorithm called LEFSA, which stands for Linear Discriminant Analysis Effect Size. It was developed by Curtis Huttenhauer at the Harvard School of Public Health. And what it does is allow you to find out which bacterial taxa are enriched in one or another group. And I'm not going to go into great detail, but I'm just going to tell you that in the children with low birth weight, their microbiomes were enriched in bacterial taxa that are inflammogenic, so Enterobacteriaceae and species in the Proteobacteria group which cause inflammation. Those in the normal birth weight were enriched in the so-called good bacteria or probiotic bacteria like Bifidobacterium longum. So what I'm showing you today, we have a lot more data which I'm not showing you, but I'm showing you that with increasing age in India as in other countries, there is an increase in the diversity of the microbiota with age. There is also a change in the relative abundance of different bacterial species. I haven't shown you that data. And that the microbiomes or the microbiota of children who are low birth weight and who have stunting is different and contains more inflammogenic bacterial species than children with normal birth weight who are not stunted. And this suggests that if we could modulate the microbiome such that we reduce the number of inflammogenic species, and increase the number of probiotic species, we may be able to intervene in infection and stunting. There's a lot more that we need to do. These are some of the things that we are planning to do in the future. First of all, look at much larger numbers, then look at the actual function of the bacteria and how they are affecting the microbiota. Also, we want to look at associations with associated conditions such as environmental enteropathy, inflammation, immune activation. We want to look at barrier function and absorption. And then eventually we hope to develop interventions that will modulate the intestinal microbiome and lead to reduction in infection and stunting. So with that, and I've listed here some of the interventions. I'll stop and happy to take questions.